Good morning, class.
Good morning, sir.
How are you doing today?
We are fine, thank you. And you?
By God's grace, I am doing very well today. This is the second year midwifery class, and as we are already aware, this semester we are supposed to do anatomy and physiology of human reproductive system and the fetus 1. The course code is RMD 201. It's a 3-credit hour paper. Last week we began talking about the description of the pelvis, and this morning I want us to finish with the types of pelvis, and then we will move on to talk about different topics, hopefully the pelvic floor. Once again, your lecturer, my name is Mr. Kwaku Dwomoh. I have an MPhil in Human Anatomy and Cell Biology from KUST. Currently, I am also pursuing my second master's degree, that is MPhil Nursing at the University of Ghana in Legon. I also have a BSc Nursing from KUST in 2008. I also have Diploma in Education from the University of Education, Bineba Kumasi campus, now Amsterdam. I am a registered general nurse, currently at the level of the Deputy Chief Health Tutor or Deputy Chief Nursing Officer. And I also double as the HOD for nursing or the head of department for nursing at the Nursing and Midwifery Training College in Korofin. So this morning, our lecture is on the types of pelvis. Let's say types of pelvis.
Types of pelvis.
Types of pelvis.
Types of pelvis.
So this morning we are going to talk about the types of pelvis. Our learning objectives, I said that we are going to talk about the types of pelvis and then their effect on labor. So we are going to talk about the types of pelvis and their effect of labor. And then we will also do pelvic assessment. When the pregnant mother comes to the antenatal clinic, how do we assess the pregnant mother to know whether the mother has the normal gynaecoid pelvis or any other type of pelvis? So these are reading materials. Once again, you can go to the school's main library and then pick any of these books. So there are a very good midwifery book. That's Anatomy and Physiology Applied to Obstetrics. Then you can also pick the Ross and Wilson, CDR Studies, Grace Anatomy for Students, more clinically oriented anatomy, and then the Frank H. Netter's Anatomy, where you can see the actual pictures of the pelvis. Now, according to Caldwell and Molloy, there are 4 main types of pelvis. Let's say 4 main types of pelvis.
4 main types of pelvis.
So apart from the 4 main types of pelvis, there are other types that we will talk about. But the 4 main types of pelvis, the first one is called the gynaecoid or the normal female pelvis. Let's say gynaecoid pelvis.
Gynaecoid pelvis.
Gynaecoid pelvis.
Gynaecoid pelvis.
Okay, so the gynaecoid is the same as the normal female pelvis. The gynaecoid or normal female pelvis. Then the next pelvis is called the android or the male pelvis. Let's say android or male pelvis.
Android or male pelvis.
Again.
Android or male pelvis.
Then the third type of pelvis is called the anthropoid pelvis. Let's say anthropoid pelvis.
Anthropoid pelvis.
Anthropoid pelvis.
Anthropoid pelvis.
The anthropoid pelvis is also known as the ape-like pelvis. Let's say anthropoid or ape-like pelvis.
Anthropoid or ape-like pelvis.
Then the last type of pelvis is called the platypelloid pelvis. Let's say platypelloid pelvis.
Platypelloid pelvis.
Platypelloid or kidney-shaped pelvis.
Platypelloid or kidney-shaped pelvis.
Yes, the platypelloid or kidney-shaped or the flat pelvis. So these are the 4 main types of pelvis according to Caldwell and Molloy. So this morning our major focus would be we want to discuss the features of the 4 main types of pelvis and their effects on labor. So let's begin with the gynaecoid pelvis. As I've already indicated, the gynaecoid pelvis is the normal female pelvis found in about 50% of all women, and that is the most suitable pelvis for childbirth. It is found in women that has all the normal female characteristics. So what are the features of gynaecoid pelvis? Now, number one, the pelvic brim is well rounded. Let's also say the brim is well rounded.
The brim is well rounded.
So in the gynaecoid pelvis, the pelvic brim or the inlet is well rounded. That is the first cardinal feature of gynaecoid pelvis. It also has a very shallow cavity with a well curved sacrum. That is the whole of the sacrum is well curved. And then the ischial spines are blunt. They are not sharp. Neither are they prominent. In the gynaecoid pelvis, the ischial spines are blunt. They are not sharp. Neither are they prominent. And then also the pubic arch in the gynaecoid pelvis is well rounded. It is not narrow. Neither is it too wide. The pubic arch or the subpubic angle is not narrow, and it is not also too wide. It is well rounded. And then the sciatic knot. Here we are referring to the greater sciatic knot and then the lesser. The sciatic knot is also very wide and is found in women of average build with a height of and a shoe size of 4 or large. So these are the cardinal features found in what? A gynaecoid or the normal female pelvis. Now, what is the effect of gynaecoid pelvis on labor? Now, we say that because the pelvic brim is well rounded, the fetus normally presents with the most rounded part of his head or the occiput anteriorly, and that is the most favorable position at the start of labor. So, for gynaecoid pelvis, mechanism of labor is always normal. Let's say normal.
Normal.
So in the gynaecoid pelvis, it always brings about a normal labor. Now the next type of pelvis is called the android or the male pelvis. Let's say android or male type of pelvis.
Android or male type of pelvis.
This type of pelvis is found in heavily built women. Women with masculine features. Heavily built women. And it's found in about 20% of all women. For the android pelvis, the brim is heart-shaped. Let's say the brim is heart-shaped.
The brim is heart-shaped.
So for the android pelvis, the pelvic brim or the inlet is more heart-shaped. So this means that the forepelvis, that is the anterior part of the cavity of the pelvis, is going to be narrow. So android pelvis has a narrow forepelvis. And then in this case, the transverse diameter will be more found at the back. So the transverse diameter is more found at the back or the posterior region of the pelvis. So there's more room available at the posterior region of the android pelvis. So the brim is heart-shaped, as I've drawn on the board, and then it has a narrow forepelvis. And I'm saying that narrow forepelvis simply means that the anterior part of the pelvic cavity is very wide, narrow. And then there's less space in the mid-pelvis as well. And then, as I've already indicated, the transverse diameter is located more toward the back, towards the sacral region. And then this also means that there's more space at what? At the posterior region or at the back of the pelvis. Bones in android pelvis are heavier because we said that android pelvis is found in what? Heavily built what? Women. So bones in android pelvis are heavier. Again, the whole of the sacrum is almost straight. You realize that we just mentioned that in the gynaecoid pelvis, the hollow, there is what? A well-curved hollow of the sacrum. But in the android pelvis, the hollow is almost straight. So it has a very poor curve, and then has a very longer sacrum, giving the cavity a funnel-shaped appearance. It gives the cavity a funnel-shaped appearance. Again, in android pelvis, the sciatic knot is very narrow. The sciatic knot, the greater sciatic knot, is very narrow. the pubic arch or the subpubic angle in android pelvis is also less than 90 degrees. And that means that the pelvic outlet is going to be contracted because the subpubic angle forms part of the diameter of what? The pelvic outlet. And because it is very narrow, then the pelvic outlet is also going to be what? Contracted. The ischial spines separating the greater sciatic knot and the lesser sciatic knot. The ischial spines in android pelvis are very sharp. Let's say very sharp.
Very sharp.
Or you can say they are more what? Prominent. They are very sharp or they are more prominent. And I've already indicated that because of the reduced subpubic angle, because the subpubic angle is very narrow, the transverse diameter of the outlet is going to be what? Reduced. Is that clear? Now, what is the effect of android pelvis on labor? Now, because the hind pelvis is more rounded, and I've already indicated that there's more space at the back than what? The front. Why? Because the anterior part is more narrow because of the heart-shaped what? Brim. So because there's more space at the posterior part of the cavity, the occiput is more likely to lie in the posterior position or the posterior quadrant. Let's say posterior quadrant.
Posterior
So
quadrant.
the occiput of the fetal head lies more in the posterior quadrant of the pelvic cavity in an android pelvis. Now, in an android pelvis, the rotation of the fetal head during labor is not possible due to the narrow forepelvis. Because the anterior part of the pelvic cavity is very narrow, rotation is also not possible. And this may lead to what we call prolonged labor. Let's say prolonged labor.
Prolonged labor.
However, if you have a very good midwife, the midwife will be able to deliver the baby normal. At times, the baby can be born face to pelvis, and that is also known as the persistent occipito-posterior position. Let's say persistent occipito-posterior position.
Persistent occipito-posterior position.
Again,
Persistent occipito-posterior position.
And some babies can also be born in face presentation. Now, because the ischial spines in android pelvis are also very prominent, at times it prevents descent. Descent is the normal movement of the fetal head through the birth canal. Because of the sharp ischial spines, at times it prevents descent. And then the narrow pubic arch will also not allow the delivery of what? The occiput, because it reduces what? The diameter of the pelvic outlet. In this situation, there will be the need for what? Manual rotation of the fetal head. Let's say manual rotation of the fetal head.
Manual rotation of the fetal head.
And then there will also be the need for either cesarean section or instrumental delivery. So that is the effect of android pelvis on labor. The third type of pelvis, according to Caldwell and Molloy, is platypelloid pelvis or the flat pelvis. Let's say platypelloid or flat pelvis.
Platypelloid or flat pelvis.
This may be due to either developmental, rachitic, or hereditary factors found in about 5% of women. You know, in Africa, as it is a custom that most African women normally carry heavy loads in their developmental years. And then from Anatomy and Physiology 1, ossification, formation of bones, we learned that both formation or ossification begins before birth and it's not complete until puberty. So what it means is that during your developmental years, if you are carrying heavy weights on your head, it will affect the formation of your bones. And similarly, especially with tired women who are always carrying heavy loads, you can see a 12, 13, 15, 17, less than the 21-year mark where the pubertal hormones will cause ossification to be complete. And so, women that normally carry heavy loads on their head, it will affect the formation of what? Their pelvis. And this is one of the main reasons why a woman may grow up to have what? A flat pelvis. So what are the features or the cardinal features in the platypelloid or a flat pelvis? Now you say that for a platypelloid pelvis, the brim or the pelvic inlet or the brim is kidney or bean shaped. Let's say kidney or bean shaped.
kidney or bean shape.
So that is what a platypelloid pelvis. A platypelloid pelvis. The pelvic rim is kidney or bean shaped. So for a platypelloid pelvis, we are saying that the pelvic rim may appear like this. This is a kidney or bean shape. So that means that the AP diameter is going to be very short, right? That is the anterior posterior diameter of the brim. It's going to be very reduced or very short. However, the transverse diameter is going to be more wide. So because of the nature of the pelvic brim, the AP diameter is going to be very narrow or short, and then the transverse diameter is going to be very wide. I hope this is self-explanatory. Yes. Due to the nature of the pelvic brim, the anterior posterior diameter is very short. And so the AP diameter is very short or reduced, and then the transverse diameter is very wide. That is one of the cardinal features of platypelloid pelvis. The side walls diverge. It also has a very flat sacrum. So it means that there is no concavity in the hollow of the sacrum. It has a flat sacrum. And then the subpubic angle is very wide. The subpubic angle is very wide. Remember, we said that if the subpubic angle is very narrow, then it is likely to lead to a contracted pelvis. Therefore, if it is very wide, then the outlet is also going to be more wide. Is that clear? Yes. Good. Now, what is the effect of platypelloid pelvis on labor? Now, the fetal head finds it difficult to engage with the pelvic brim and usually present with a long diameter of the head across the transverse diameter. Why? Because we said that there's more room or more available space in the transverse, but the AP is very short. Now, again, because of the high head, now high head simply means the possibility of the fetal head positioned high in the uterus. So because of the high head, membranes are more likely to rupture, and there is also the possibility of cord prolapse in platypelloid pelvis. However, with very good uterine contractions, the fetal head can be pushed to and fro, let's say to and fro. From the promontory of the sacrum to the symphysis pubis. Again, the head can also rock and roll from the pelvic brim toward the cavity. And then this will make the bones of the skull to overlap. Let's say overlap. When the bones overlap, because of the sutures in between the cranial bones, the pressure will cause it to overlap. And this whole process is called asynclitism. Let's say asynclitism. And normally, in most situations, it may be followed by rapid delivery of the head. In platypelloid pelvis, baby may be born face to pelvis. And there will also be a need for cesarean section, especially if the pelvic brim is very reduced or if the diameters are very contracted. There will be a need to do cesarean section to avoid any injury to both the mother and the baby. So that is the effect of platypelloid pelvis on labor. The last major type of pelvis is called the anthropoid pelvis. Let's say anthropoid pelvis.
Anthropoid pelvis.
Anthropoid pelvis.
Anthropoid pelvis.
This is found in very tall, long-legged women with narrow shoulders. Let's say very tall.
Very tall.
Long-legged.
Long-legged.
Women. With narrow shoulders.
With narrow shoulders.
Anthropoid pelvis is found in very tall, long-legged women with narrow shoulders. Found in about 25% of all women. So what are the features of anthropoid pelvis? The brim is also oval. So the brim is oval shaped. So in this case, what it means is that the AP diameter is more longer than the transverse diameter. And if you want to compare the AP and the transverse to that of the platypelloid, we can say they are directly opposite. In platypelloid, the AP was very short, the transverse was very wide. But in the case of Anthropoid, the AP diameter is very long, but the transverse diameter is what? Is reduced. In Anthropoid pelvis, the ischial spines are not prominent. The subpubic angle is also wide. Side walls are straight. The sacrum is also very long and deeply concave. And then the sciatic knot. The sciatic knot is also what? Very wide. Now, what is the effect of Anthropoid pelvis on labor? So, as midwifery student, it is important that whilst we are learning the type of pelvis, we also know the effect of the pelvis on what? On labor. So, the fetus normally presents with a long diameter of the head in the anterior posterior diameter of the brain. Why? Because the AP diameter is very wide, and there is more room in the anterior posterior diameter. And because the AP diameter is very wide, the fetal head can find it very difficult, can find it very easily to be accommodated in the AP diameter. The occiput of the fetal head normally fits in what? The hollow of the sacrum than anterior. That's the hollow of the sacrum.
Hollow of the sacrum.
For Anthropoid pelvis, labor usually do not present with any difficulties, and the fetus is mostly delivered in what we call the unreduced occipital-posterior position. Let's say unreduced occipital-posterior position. Let's say it together.
Unreduced occipital-posterior position.
That is the most favorable position where the baby is normally delivered in the Anthropoid pelvis instead of face to perineum. So that is the effect of Anthropoid pelvis on labor. Apart from the Gynaecoid pelvis, the android or male pelvis, Platypelloid pelvis, and then the Anthropoid pelvis, there are other types of pelvis. Let's say other type of pelvis.
Other types of pelvis.
The first one I want to talk about is called the justo-minor pelvis. Let's say justo-minor pelvis.
Justo-minor pelvis.
Justo-minor pelvis.
Justo-minor
Now, the justo-minor pelvis is also known as the small gynaecoid pelvis. So what we're saying is that this is the type of pelvis found in women having the normal female characteristics of a gynaecoid female shape. So the woman has all the female characteristics, but the only problem is that this woman is less than 1.5 meters tall. They are very short women, but their shape have all the feminine characteristics. They have all the features of a woman for a gynaecoid pelvis, but their only challenge is that they are petite women. Let's say petite women.
Petite women.
Petite is a French word that means what? Short. So petite or small women, they are found in short women less than 1.5 meters tall. So what it means is that for them, you know, for the normal gynaecoid pelvic AP, the pelvic brain is what? 11, 12, and what? 13, right? But for justo-minor pelvis, all their diameters are reduced for both the brain, the cavity, and what? The alveolus. The effects of justo-minor pelvis on labor. Vaginal delivery is possible on one condition that the baby that the woman is about to deliver is small. So what it means is that when this woman is pregnant, if the woman keeps on eating plenty caloric meal and the baby is very large, then it will become difficult for the baby to do what? Deliver the vagina. But if the baby is small, then the baby can be what? Delivered. But if the baby is a very large baby, the spontaneous vaginal delivery is not what? Possible. In such women, there will be the need for what? Caesarean section. The other type of pelvis is called contracted pelvis. Let's say contracted pelvis.
Contracted pelvis.
For contracted pelvis, all the diameters are reduced by 1 centimeter or more. And under that, we're talking about what we call the Robert's pelvis and then the Nigelis pelvis. Let's say Robert's pelvis.
Robert's pelvis.
Nigelis pelvis.
Nigelis pelvis.
So what is Robert's pelvis? I remember last week I told you that in some of the pelvis, the ala or the wings of the sacrum can be missing. And this is where we are. In Robert's pelvis, there are no ala of the sacrum. So in Robert pelvis, there are no ala. What it means is that the promontory of the sacrum is fused directly to what? The joint. So the sacroiliac joint in Robert pelvis is not between the ala and what? The ilium, but it's between what? The promontory and the whole sacrum and that of what? The pelvis itself. So all you need to remember in Robert pelvis is that in Robert pelvis there are no ala of the sacrum. There are no ala of the sacrum. Therefore, all its diameters are greatly reduced. For this type of pelvis, it will be difficult for the woman to deliver her what? Vagina. That is, it will be difficult for the woman to have a normal spontaneous vaginal delivery. And one of the major causes of Robert pelvis is congenital abnormality. Let's say congenital abnormalities.
Congenital abnormalities.
So for Robert pelvis, the mode of delivery is strictly by what? Caesarean section. The next type of pelvis is the Nigelis pelvis. Let's say Nigelis pelvis.
Nigelis pelvis.
So whilst in Robert pelvis there are no ala of the sacrum, in Nigelis pelvis there is only one ala. There's one missing ala. There's only one word, ala of the sacrum. And this results in, if there is only one ala, then it is going to result into what? Obliquity pelvis. And it's going to cause an oblique pelvis, right? Let's say obliquity pelvis.
Obliquity pelvis.
And Nigelis pelvis is also due to what? Congenital abnormality. It may also be due to injury. Nigelis pelvis may also be caused by injury. And the mode of delivery is also strictly by caesarean section. So what are some of the possible causes of contracted pelvis, either Nigelis or Robert pelvis? Number one is poor dieting during your developmental years. For example, we know that the pelvis is made up of bones, right? And one of the important nutrients for bone development is what? Calcium, vitamin D, that will promote the absorption of calcium, and then what? Phosphate or phosphorus, right? And so if you take food less in calcium, then it means that it's going to affect the formation of your bones, and that can also affect the formation of your what? But congenital abnormality can also be upon limping. Limping for so many years can lead to obliquity pelvis. Injury to the child during the developmental years. And then I also mentioned that if you carry heavy loads on your head, it can also affect the formation of your what? Pelvis. So these are some of the causes of contracted pelvis. Now, the last type of pelvis I want to talk about is called the rachitic pelvis. Let's say rachitic pelvis.
Rachitic pelvis.
Yes. This is mainly due to rickets. And that is, rickets simply means what? Inadequate intake of what? Vitamin D, right? Inadequate intake of vitamin D. So it normally happens in children. So in women, as they are developing, if they are not being given enough vitamin D in their diet, it results into what we call the rachitic what? Pelvis. So there is bone pain, poor growth, and weakness of their bones. In adults, it is called osteomalacia pelvis. That is, these individuals have very weak pelvis. Their bones are very what? Weak. Due to what? Inadequate intake of what? Vitamin D in the diet. Because we know that vitamin D will promote both the absorption of calcium and what? Phosphorus, to lead to strong bones and strong teeth. And so if during your developmental years you are not taking enough calcium in your diet, then that can lead to what? An osteomalacia or rachitic pelvis. For such individuals, they may have bow legs, deformity of their spine, and then their AP diameter is severely reduced. That is, the obstetrical conjugate is reduced. Sacrocortical diameter is also reduced, and all other diameters are reduced. And for these individuals, it will be difficult for them to have spontaneous vaginal delivery unless by what? Caesarean section. So these are the various types of pelvis that we have and their effect on labor. Now, as a midwife, during antenatal care, when our pregnant mothers come to the ANC, how do we assess the pelvis? The first key thing is what we call observation. Let's say observation.
Observation.
By just observing the height, we just learned that women with a height less than 1.5 are more likely to have what? Just minor pelvis, right?
Yes.
Yes. So by observing the height, their weight alone, their shoe size, we could just predict the type of pelvis that the woman is having, right? So if you have a pregnant mother very short, then automatically you may be thinking that this woman is likely to have what? A just minor pelvis, and therefore it is very important to you as a midwife to give the right education that if this woman wants to deliver spontaneously per vagina, then the woman will have to cut down calorie intake but take more nutritious meal so that the baby will not be what? Very large. But if the baby is very large, then the only means will be by what? Cesarean what? Section. Is that clear?
Yes.
So a very short woman can give you an idea. Again, we also know that a very tall, long-legged woman is more likely to have what? Anthropoid what? Pelvis. So if you see a very tall, long-legged woman with narrow shoulders and pregnant coming to your ANC as a in charge, that physical observation alone should give you a clue about the type of pelvis that the woman is having. Again, if you see a very masculine, heavily built woman, then it can also give you an impression that hey, it's likely this woman is likely to have what? An android or what? A male pelvis. Again, the woman is coming and is limping, an obliquity pelvis. Okay? That should also give you an indication that probably maybe one of the ala is what? Missing due to congenital abnormality. So as a midwife, just by physical observation, you should be able to predict the type of pelvis that the woman is having. Then, history taking. Let's say history taking.
History taking.
Yes. By careful history, by getting to know the previous labor, outcome of vaginal deliveries, was it a 36 to 40 week gestation? So if the woman, by just ANC, from assessment, if you inquire from the woman and the woman tells you, oh, I'm a multi-para or multi-gravidal woman, I've had about 10 deliveries, then automatically this should give you an indication that the woman has what? A very good pelvis. I've had 10 deliveries with no complication. They were all spontaneous vaginal what? Deliveries. Then that should tell you that this woman is likely to have what? A normal female what? Pelvis. Now, family history is also very important. Again, still about deliveries. If the woman tells you during ANC that as for me, I've had 2 deliveries, but they were all by CS, then that should give you an indication that, hey, then probably there could be a problem with the woman's pelvis. That is why all those 2 deliveries were what? By CS. So that would mean that you need to do further assessment. Okay? You will need to do further assessment. Now, family history is also very important. Some type of pelvis runs in certain families. We said that for Caucasian women, they have anthropoid what? Pelvis. That is why at the antenatal clinic, you also have to take what? Family history. But the ethnicity alone can give you an idea about the type of pelvis that the woman is having. And then after taking history, the next thing that you have to do is what we call pelvic assessment. Let's say pelvic measurement. Let's say pelvic measurement.
Pelvic measurement.
Now, this type of measurements are found in remote areas and where you don't have a lot of very good work. Where pelvic assessment is not available, so there are less sophisticated machines to do assessment. So if the midwife is working alone in a remote area, then there will be a need to do 3 key measurements. The first one is interspinal diameter. Let's say interspinal diameter.
Interspinal diameter.
Now this measurement will be done by an instrument on the board called pelvimeter. Let's say pelvimeter.
Pelvimeter.
What you see on the board are various types of what? Pelvimeters, right? So that is the instrument that we are going to use to measure. So this is a toe pelvimeter, Lee pelvimeter, Snyder's pelvimeter, Briskill's pelvimeter, Cullen pelvimeter, and then Martin's pelvimeter. So you can use any of these instruments to check these 3 key measurements. Interspinal diameter is measured between the 2 anterior to superior iliac spine. So from this anterior superior iliac spine to this, so from here to there, right? That is the interspinous diameter, and it usually measures 25.5 centimeters. Then you can also do an intercristal diameter assessment. Measure between the two widest points of the iliac crest. So this is the iliac crest. So between the two widest points on what? On the iliac crest, and that will also measure 28 centimeters. Let's say 28 centimeters.
28 centimeters.
So the intercristal diameter always exceeds that of the interspinous by what? 2.5. Remember the interspinous was 25.5, and then the intercristal is what? 20. So the difference is mostly 2.5. Now, if the difference is more than 2.5, then that should give you an indication that the woman is having what? A flat what? Pelvis. And then the last one to measure with the pelvimeter is the external conjugate. Let's say external conjugate.
External conjugate.
It is measured from where? The upper part of the upper anterior border of the symphysis pubis here. From the upper border of the symphysis pubis all the way to the tip of what? All the way to the tip of the fifth lumbar vertebrae. So let me take the external conjugate again. The external conjugate is measured from where? The upper border of what? The symphysis pubis all the way to what? The tip of the spine of what? The fifth lumbar vertebrae. And it also measured to what? 90 centimeters. These are key measurements that can be taken to assess that of what? The pelvis. Then you also take the transverse diameter of the outlet. So here the woman lies in the normal position for vaginal examination. Normal position for VE. The midwife will wear the glove and then make her hand into a fist and place it in between the woman's ischial tuberosity from here to here, right? So you make a fist in between the two ischial tuberosity. And we're saying that once this diameter admits all the four knuckles of your clenched fist, then it can also give you an idea that the woman is having a normal what? Pelvis, like this. You realize that it has admitted all what? My four fists. Is that clear? And for your normal clenched fist, the measurement is between 7.5 to what? 9 centimeters. So when you add all the subcutaneous tissues, it should give you an actual measurement of about 10 to what? 11 centimeters between. So this is the ischial tuberosity and that. So you make a clenched fist in between the two ischial tuberosities. Alright, so the next pelvic measurement that you can also do is the external conjugate with the help of the pelvimeter, where you measure it from the upper border of the symphysis pubis all the way to the tip of what? The fifth lumbar vertebrae. And it also measures 19 centimeters. Then as a midwife, you also need to assess for the transverse diameter of the outlet. Let's say transverse diameter of the outlet.
Transverse diameter of the outlet.
So how do you do it? You allow the woman to lie in the normal position for vaginal examination. And then you wear your gloves. And then you make your hand into a fist. And then you try to put your fist hand in between the two ischial tuberosities. We said that the ischial tuberosities help her to walk, to sit. So you place your hand in between the two ischial tuberosities. And the four knuckles of the clenched fist should be able to walk, pass through this diameter. So your four knuckles normally is between 7.5 to 9 centimeters. But when you add all the subcutaneous tissues of your hand, it should be between 10 to what? 11.5. And once your clenched fist is able to move in between the ischial tuberosities, then it gives you an indication that the woman is having an adequate what? Pelvis. Is that clear? The next thing that you also have to do during antenatal care is abdominal examination. Let's say abdominal examination.
Abdominal examination.
This is very key for us to know that a pelvis cannot be said to be adequate until the widest transverse diameter of the fetal head has been able to pass through the pelvic brim. Once the widest transverse diameter of the head passes through the brim, then automatically it can also pass through the cavity and then come out of what? The outlet. Are you getting it? So an adequate pelvis is the one where the widest transverse diameter of the head has been able to pass through what? The brim or the pelvic what? Inlet. So around 36 to 37 weeks of pregnancy, the abdomen is palpated to see whether the fetal head is what? Engaged, or it can be made to engage. So here, engagement, we want to see whether the widest transverse diameter has been able to fit on the pelvic what? Brim. Are we there?
Yes.
Yes. So if it is not fitting, then the midwife can push the head through what? The pelvic brim. Now, if the fetal head cannot be made to engage, if the head cannot fit on the pelvic brim, then it tells you that there could be a problem. So there will be a need to refer it to what? An obstetrician. So an obstetrician would have to come in and do this assessment to assess for what? The adequacy of the woman's pelvis. Now again, during abdominal examination, the woman's bladder has to be empty. So the woman will have to what? Pass urine to empty the bladder. Now the upper margin of the symphysis pubis must be well defined. And then the levels of the occiput and sinciput must be accurately defined as well. And then once the head is engaged, we are saying that it is no more ballotable above what? The symphysis pubis. If it's engaged, it means that it has well fit on what? The brim. So it is not ballotable above the symphysis pubis. And the degree of engagement is measured in what? In feet. So if it is engaged, it is no more 5/5, but 4/5 or what? 3/5. Now again, one important pelvic assessment that the midwife has to do at the antenatal care is what? Vaginal examination. Let's say vaginal examination.
Vaginal examination.
Yes, also known as what? VE. VE. And I remember during my nursing training days, when we went to the labor ward, and as a male, I was asked to go and do a VE. I remember all the males were doing this. We were ready to put our hand somewhere, right, into the vagina to assess, and it was a very beautiful experience. So pelvic assessment is also done by vaginal examination to help exclude any abnormality of the pelvis and its content. So what do? The first thing to check is the diagonal conjugate. Let's say diagonal conjugate.
Diagonal conjugate.
And this is measured from where? The lower border of the symphysis pubis. From here, from the lower border of the symphysis pubis, all the way toward the sacral promontory. So you check for the diagonal conjugate. So during vaginal examination, the index finger and the third finger, as I showed you, are stretched in an attempt to reach the sacral promontory. V, you stretch it. You measure the measurement to reach the promontory of the sacrum. Once the sacral promontory cannot be felt, then it means that the diagonal conjugate and the pelvic brim is said to be what? Adequate. But if it can be felt, then it means that the diagonal conjugate is what? Is reduced. Because the conjugate is from where? The lower border all the way to the sacral promontory. So if you cannot feel the sacral promontory, then it means that what? The diagonal conjugate and the brim is what? Adequate. In the normal situation, you are not supposed to feel the sacral promontory. But if you are able to feel it, then it means that the distance is very short. That is how come your hand is able to go all the way to what? The sacral promontory. Is that clear?
Yes.
And once you feel it, and then I'm saying that if you feel it, then it means that the diagonal conjugate is reduced. Then they need to refer this woman to what? The obstetrician for further investigation, to let the obstetrician know that the diagonal conjugate is very what? Is very short. And then the obstetrician will do further assessment. And then whatever has to be done will be done for this woman to prepare the woman for what? A successful delivery. During vaginal examination and abdominal, sorry, I think I've gone back. So again, you can also assess for the hollow of the sacrum. So the pelvic cavity is assessed by feeling for the hollow. You also feel for the hollow of what? The sacrum. It should be what? Well concave and not straight. And then you also check the outlet for the ischial what? Spines. During vaginal examination, you check the outlet for the ischial spine. It should be it should not be prominent, and it shouldn't be what? Sharp. we've learned that if the ischial spines are sharp and prominent, it reduces what? The diameter of the pelvic what? Armlet. Then you also feel for the subpubic angle or the pubic what? Arch. It should be well rounded and it should be able to admit 2 what? Fingers. The pubic arch should be able to admit 2 fingers. They will say that if this is not possible, they will say that there is a narrow pubic arch. If your 2 fingers cannot pass through the subpubic angle, then there's a narrow what? Pubic arch. And a narrow pubic arch also is an indication of what? A contracted pelvic what? Outlet. That's a contracted pelvic outlet.
Contracted pelvic outlet.
Then we also know that a very wide pubic arch is also what? A flat what? Pelvis, right? So all these are very important for you to know the type of pelvis that the woman is having. Now we've talked about several assessments that can be done at the antenatal clinic. We've mentioned normal observation, history taking, abdominal examination, vaginal examination, taking the transverse diameter. But the most accurate of all is by taking what? An X-ray of the pelvis. Let's say X-ray of the pelvis.
X-ray of the pelvis.
That is what X-ray pelvimetry. This is the more accurate method of estimating the relationship between the maternal pelvis and what? The fetal head. It can be done anytime when the client is not pregnant. But as soon as the woman is pregnant, it should not be done before 36 weeks of gestation. Because the radiations can cause congenital abnormalities, right? So we don't want to have deletion, insertion, duplication, and all that to cause several chromosomal abnormalities. So X-ray must be done before, must not. X-ray pelvimetry or taking an X-ray of the pelvis, it must not be done before what? 36 weeks to avoid radiation effect on the fetus. That can lead to what? Chromosomal abnormalities. And then before the examination is carried out, the client's bladder, so the pregnant mother has what? Empty the bladder, and then the rectum has to also be what? Empty to have normal milk. And once you get the X-ray, you can look at the X-ray and then look at the diameters of the brim, the AP diameter. You can check what? The transverse diameter. And then you can also check for both the brim, the outlet, right? You say this from one ischial tuberosity to what? To the other. So you can check, do your measurement on the X-ray, and this measurement will help you to be able to assess whether the woman has what? A normal pelvis or an abnormal one or a problematic one. And once you know the type of pelvis, it also help define or help suggest to the team as to the best type of delivery method that should be advised for the mother, either by spontaneous vaginal delivery or by what? Cesarean section. So generally, what are the general functions of the pelvis? Number one, it houses and protects the pelvic organs. Let's say it together.
It houses and protects the pelvic organs.
So in the mother or in women, what are the pelvic organs? The ovaries, the fallopian tubes, that will receive what? The oocyte during ovulation, and then the oocyte will travel through the fallopian tube to what? The uterus. The uterus is also in the pelvis, the vagina, the lower end of the uterus is what? The cervix. They are all in your what? In your pelvis. So one key function of the bony pelvis is that it houses all the female reproductive organs in the female, and then the male reproductive organs in what? In the male. It also facilitates what? Childbirth. We've learned that for the true pelvis there is the brim, the cavity, and what? The outlet. And we said that during labor, the head has to engage on the brim, and then there should be descent through what? The pelvic cavity before the baby can now be what? Be delivered. It also transmits the weight of the trunk to the legs, and then with the help of the ischial tuberosities, the pelvis also helps us to what? To sit. So on this note, we come to the end of our lecture. These are our references, and then this is the end of our lecture. Any questions on the types of pelvis that we have discussed so far? So far we've discussed about the 4 main types of pelvis: the gynaecoid or the normal female pelvis, the android or the male pelvis, the platypelloid pelvis, and the anthropoid pelvis. And we also talk about other type of pelvis, the justo-minor pelvis found in a woman less than 1.5 meters tall. We also discussed the Nigelis pelvis, the Roberts pelvis, the rachitic pelvis, contracted pelvis, and their effect of labor. And we also did pelvic assessment as well. Any question on what we've done so far today? Is there any question? Yes, ask your question. You mention your name and then you ask your question.
Kuma Benedicta.
Kuma Benedicta. Okay.
So I've been hearing that mostly the midwives will tell the pregnant women that they should do more exercise. So my question is that, is the exercise going to change their type of pelvic they are having, or maybe the exercise is going to... And then my second question is that...
So let's be more specific on your first question. Your first question is that midwives tell pregnant mothers to do a lot of exercise, and you're asking whether exercise will change their type of pelvis. And a question well understood.
And then my second question is that, are there different types of pain when pushing, using the pushing technique in childbirth, when you have the different types of pelvic, like maybe the pregnant women, different, are they going to experience different type of pain when pushing? And then the last is, can a woman have a mixed pelvic type?
A woman having gynaecoid and android at the same time. All right, thank you for your question. So the first, let me take your questions one by one. The first one was whether, Benedicta, the first question was whether exercise can change the type of pelvis. Good. So from normal ossification, then we learned in anatomy 1, the formation of bones begins whilst you are in the uterus, and then it is not complete till puberty. So we've estimated it to be around 21 years. Once ossification is complete, you will no longer be able to form a different type of pelvis again. So what is going to be the exercise? Why are midwives advising that pregnant mothers have to do exercise, the Kegels exercise? Very important. Now, this is the bony pelvis. There are structures that support the content of the pelvis. Remember I told you that the uterus, the ovary, everything is in the cavity. Now, assuming this is the uterus, if it is in the cavity like this and nothing is supporting it to stay in the cavity, and I leave it like this, it will come out, right? It is called prolapse. So there are structures that support the content of the pelvis. So now if it is the ovary, and then I place my hand there, is it coming out? No. So the structure that support the content of the pelvic is called the pelvic floor. Let's say pelvic floor.
Pelvic floor.
So next week, we will do pelvic floor. And you understand that pelvic floor has muscles. There are superficial pelvic floor muscles and then deep pelvic floor muscles. And these muscles, when you exercise, it strengthens the muscles. And it will also allow for what? A spontaneous delivery. So if you don't exercise the muscles, then during delivery, there could be the possibility of more tears. So next week, we will learn about first degree tear, second degree tear, third degree tear. So exercising the muscle will limit what? The tears. Are you there? And then your second question was, can a woman have two types of pelvis? This one, I expect you to answer. What is the answer?
No.
Yeah? No. How can you have gynaecoid and then, what do you call it, android pelvis at the same time? We don't have hermaphrodite pelvis. We don't have hermaphrodite. You know what a hermaphrodite is? I mean, you don't have both male and female sex organs. So the individual has both penis and vagina at the same time. We don't have hermaphrodite pelvis, where someone has both gynaecoid and the android at the same time. And then your last question was on pain. Yes, of course. Pain has, even with normal pain, there are different levels of pain. Acute pain and what? Chronic pain. So automatically there will be different type of what? Pain levels. Any other question? Alright, so if there are no questions, on this note, we come to the end of our types of pelvis. So God willing, next week, we will talk about the pelvic floor. Thank you very much and have a lovely day.